We are live.
A very good evening to all distinguished delegates and today's eminent faculty, Dr. Rakesh Sarkar sir. I would like to welcome all from Zydus Life Sciences. This is a program called CLEARTalk. CLEARTalk is one more facet of Unite Against Dyslipidemia. And I would like to welcome all our delegates today. And I would like to give a small brief introduction about Sir. Dr. Rakesh Sarkar sir is MD DM cardiologist. He is a senior consultant cardiologist and electrophysicist from BF Birla Heart Research Center, Kolkata. Sir has huge professional experience. Sir has clinical experience in clinical cardiology, echocardiography, TTE and TEE, interventional cardiology, more than radial angiography, more than 500, radial angioplasty, more than 100, femoral angiography, more than 1,000. And this is his expertise and professional experience. Sir has special interest in AF, VT ablation and his bundle pacing. Of course, Sir has more than 26 original articles. So we have one of the best faculty to speak about clear outcomes trial, that is late breaking clear outcomes trial, which was presented in American College of Cardiology 2023. So I would like to hand over this session to Dr. Rakesh Sarkar sir without wasting much of our time.
So thank you for the kind introduction. Let me share my screen. Yeah, am I now visible with my slides?
Yes, sir.
So without wasting much time, first of all, at the outset, I would like to thank Zydus for having me for just discussion on this particular topic on bempedoic acid, which is considered to be one of the most recent arm in our armamentarium. So just with that particular molecule, probably will be able to shed some lights on the therapy of the lipid lipid disorders, particularly in view of hypercholesterolemia and a lot of other mixed dyslipidemia, where we have seen that statin is not being sufficient enough alone, or particularly in case of statin intolerant subset. So without much wasting time, so I would like to go in the background of this research and this all this study, why the rationale of coming of this particular molecule was considered. Now, as we all know that lipid has a very very considerable role in reducing or in particularly formation of that cardiovascular mortality and morbidity by the way of hypercholesterolemia and so many other atherosclerotic heart disease, which translates into the clinical form in the acute coronary syndrome or stable coronary heart disease, or sometimes it can result into some other non-cardiac disease in the form of stroke or peripheral vascular disease, so on and so forth. So in the list of that lipid molecules which are considered to be one of the surrogates of our dyslipidemia, like low density lipid or low density lipoprotein is considered. That means cholesterol in the form of LDL is considered to be one of the highest risk assessor in the lipid subgroups. So whatever we have seen in that particular subset, that relative risk reduction per 1 millimole per liter of LDL-C reduction results into almost 23% relative risk reduction. If we consider about the multiple registry and the trials, we can substantiate that relative risk reduction of major vascular events can be achieved by various lipid lowering agents starting from ezetimibe, fibrates, niacin, CETP inhibitors, bile acid sequestrants, even ileal bypass. But most important role is played by statins after its arrival. And last but not the least, the PCSK9 inhibitors. So whatever we have seen, the amount of relative risk reduction is being achieved by statin alone, which is derived from almost 25 trials, is a reasonably good, good molecule. And if we consider about various statin therapy starting from low intensity to high intensity, it results in a very good control of the lipid status or the standards, and the highest being the PCSK9 inhibitors, which is considered to be little expensive even at this present era. But before we talk about the bempedoic acid, which is our molecule of interest of today, so we have seen from various trials the most prominent and the promising results so far we have achieved from statins after almost 25 trials, which has been designed in a randomized control way. So as we said, that each 1 millimole per liter reduction of LDL gives more CV events reduction according to number of years in trial and comorbid conditions as well. You can see that the relative risk reduction in 1 year of trial results in 11% risk reduction, whereas gradually in 2 years it can be almost more than double, that is 24%, and in more than 6 years of therapy it results in almost 36% of risk reduction, which is considerably very high and maybe targeted at some point for taking care of our all the mess, including non-fatal myocardial infarction, CSD, death, stroke, or even other morbid factors. So what we have seen that lipid lowering of more than 5 millimole per liter results in 62% of CVD plus diabetic risk reduction, whereas if you consider, if you consider in diabetic substrate, the CVD risk reduction can be achieved of almost 62% by lowering 5 millimole per liter of LDLC reduction, whereas in non-DM person or in case of non-diabetic patient, the CVD is almost, that means the patient who are considered of not having any CVD or even not diabetic is almost 9%. So in those cases, we have seen that maximum benefit can be achieved in a diabetic substrate, whereas if you consider about the cardiovascular disease plus diabetes, even in a patient of metabolic syndrome, the gradual benefit comes from the more reduction of LDL-C. So management of dyslipidemia is high on priority, and statins are considered to be the first-line agents, as we all know at today's scenario. But the concern is, do all statin users achieve LDL-C goals as per guideline recommendation? Probably the answer we will be discussing in the next few slides. And the second concern is how to achieve LDL-C target after maximally tolerated dose of statins. So we have these two present, controversy or the conflicts, which is to be discussed in the following slides. So the first conflict is LDL-C targets. As we know that based on that the Lipid Association of India 2020 guidelines, that CVD risk stratification is done in low risk to extreme high risk patients. Like they have categorized the community into 5 groups, starting from low risk to extreme risk based on some criteria of ASCVD risk factors or other risk factors. So who are the low risk factors? Who are having 0 to 1 major ASCVD risk factor and lifetime CVD risk of less than 30%. Moderate risk means 2 major ASCVD risk factors or low risk groups with more than 1 moderate risk of non-conventional risk factors and lifetime CVD risk of more than 30%. High risk is considered when more than 3 major ASCVD risk factors are there, or 2 major ASCVD risk factors with 1 moderate risk of non-conventional risk factors, or more than 1 other risk factors. I mean, that is high risk factors. And very high risk groups are pre-existing ASCVD or diabetes with more than other major ASCVD risk factors, or any evidence of target organ damage or familial homozygous hypercholesterolemia. And the extreme risk is also categorized in 2 groups, category A and category 2, where there is CAD with more than 1 features of high risk group, that is category A. And when the CAD is more than 1 features of very high risk groups, or ACS within 1 year, even despite controlling LDLC of less than 50%, are considered to be category B extreme risk. This is the population which is having probably the highest mortality risk, including the highest risk of any major cardiovascular events. So the risk factors, as we all know, the major ASCVD risk factors are considered when age is more than 45 in male or more than 55 years in females, family history of premature ASCVD or current cigarette smoking or tobacco use, high blood pressure, low LDLC, all are considered to be in the major ASCVD risk. Other high risk factors are diabetes with 0 to 1, other major ASCVD risk factors, CKD stage 3B or 4, familial hypercholesterolemia, extreme of single risk factors, coronary calcium score of more than 300,000 per unit, non-stenotic carotid plaque, or lipoprotein A level more than 50 mg per dl, and moderate risk conventional, the other subsets which is little toned down from the high risk features of the other high risk features. So going to the next slide. Sorry, my slides is not actually moving. Yeah. So as the Lipid Association of India 2020 revised their LDLC target for Indian population based on this recent, that data which has been put together or gathered by various registry, and they have said that the extreme risk category A group should have the lipid or LDLC level less than 50 or optionally less than 30 mg per dl, which is considered to be the gold standard, and the non-HDL cholesterol level should be less than 80. Whereas extreme risk group of category B, which is considered to be the highest risk group, has to be less than 30 mg per dl as far as the LDLC level is concerned. Whereas in very high risk group, it is less than 50. In high risk group, it is less than 70. And in moderate risk group, it is less than 100. At the same time, the therapy should be considered in any of the situation, like when extreme risk group, you are considering that it has, whenever it crosses more than 50 mg per dl, that means the LDLC, or in extreme risk category of category B, when it is more than 30, it is just the vice versa. And they have said in only low risk group that LDLC, whenever is more than 130, then you start considering therapy of statin or lipid lowering agent. So coming to the ESC 2016 and 2019 comparison as far as the LDLC target is concerned. Now, we can see that till the time of 2016 and 19 guidelines are concerned, like in low risk group only, the LDLC targets are matching. That means they have kept in both the situation 115 mg per dl target, whereas from moderate risk group onwards, the ESC 2019 LDLC target range actually is differing. That means they are telling again the lower is the better. That means in moderate risk group onwards, the LDLC target has changed from 115 to 100 mg per dl. In high risk group, they have come down even from 100 to 70, and in very high risk group, they have further come down from 70 to 55, which is considered to be very significantly hot process, which can result in seriously CV risk reduction and clinical benefit. So based on the revised ESC 2019 guidelines, how many patients do have controlled LDLC? That also we need to look at. So as far as the Da Vinci study is concerned, which incorporated 18 countries in Europe and involved more than 5,800 population, among which the primary prevention was in 3,000 patients and secondary prevention was in more than 2,800 patients. Their objective was to evaluate the impact of ESC 2019 dyslipidemia management guidelines on LDLC goal achievement. So that's a cross-sectional observational study, and what the study actually, the overall outcome has found that as per the revised guideline from ESC 2019, only 27.6 eligible patients are receiving high intensity statin. So you can see that red area, which is a surrogate of high intensity statin monotherapy, whereas the green one is showing only the overall population of the lipid lowering agent therapy. The low intensity statin is being marked by the yellow, the orange is the moderate intensity therapy, and the other things are demarcated with blue and other. But interestingly, the lipid lowering therapy in the whole patient population, if you consider as per the revised guideline from ESC 2019, only 27.6% eligible patients are receiving high intensity statin, which is actually very low. And on top of that, the proportion of patients who are achieving the goal, irrespective of their level of therapy, that means the intensity of therapy, only 30% patients are achieving lipid goals with high intensity statin. So this is a major concern. And at the same time, what they have found as per the revised guideline of ESC 2019, lipid targets in very high risk patients who are having the maximum amount of risk for having the MACE, the only 37.5% eligible patients are receiving high intensity statins. So previous one was considering all the population, and here it is only considering the high risk population where there is little bit of increase in the percent or the number of the eligible patients who are actually getting high intensity statin, despite the fact only 22% patients are achieving lipid goals with high intensity statins. So in neither way, the statins are actually getting the best results, either in terms of eligibility or in terms of their clinical outcome or the adherence. So with that, the second concern, as we already discussed, that how to achieve that LDLC targets after maximum tolerated dose of statins. So this has to be addressed first if we consider about the LDLC level to control our future risk of stroke or ASCVD or any ACS. So management of dyslipidemia is high on priority And statin, despite being the first line agent, still we need to consider about some other things. So as far as the efficacy is concerned, the ASCVD patients, after checking their baseline LDLC level, if there is already some documentation of ACS or stroke or peripheral artery disease, the results are actually encouraging in terms of monotherapy to polytherapy in the form of fixed dose or other things. Like if it is the only high intensity statin alone, then the risk reduction or the benefit will be 50% of the achievement of the cholesterol level. Whereas if it is fixed dose combination of ezetimibe plus high intensity statin, little bit of improvement to 65%. But if it is bempedoic acid plus high intensity statin, it has been found that the result is increased in the tune of 65 to 70%, which is definitely a significant amount considering the high intensity statin alone. If it is high intensity statin plus fixed dose of ezetimibe and bempedoic acid, it is almost 75%. But at the same time, if it is PCSK9 inhibitors along with high intensity statin and ezetimibe, it is 85%. So in familial hypercholesterolemia also, it has been found that the ezetimibe and high intensity statin fixed dose combination can result in 65% of the achievement of the goal, whereas bempedoic acid and high intensity statin can achieve the goal in the tune of 65 to 70%, which was remaining same for ASCVD risk group. And at the same time, with the addition of ezetimibe, it can improve further with in the tune of 5% extra. And if you consider about the PCSK9 inhibitors, definitely is far better than the bempedoic acid itself. But the complete statin intolerance group, if you consider, here comes the real benefit of the other medicine like bempedoic acid or ezetimibe. So in bempedoic acid plus ezetimibe, in statin complete intolerant group, it is 40%. PCSK9 inhibitors can achieve in the tune of 50 to 60%. Ezetimibe plus PCSK9 can achieve 70%. And in case of complete statin intolerant, if you consider that 3 drug combination, which are bempedoic acid, ezetimibe, and PCSK9, it can achieve almost 80 to 85%, which is very similar to having statin therapy on board. So with high intensity statin, how low? I mean, it has been shown that it has very low adherence with the which can result in higher MACE events. So observational study of more than 23,000 post-ACS patients who were prescribed high intensity statin after index event has been seen that more than 66% of all patients presenting with ACS did not take high intensity statin after discharge, which is a very concerning data. And if you consider that more than 50% of patients had drug interruption or end of the therapy within the first month of index event, which is another alarming situation. And always, as I told that non-adherence to high intensity statin had a strong association with higher mortality by 16%, which is statistically significant, as you can see the p-value. And as the time goes on in the survival curve plot, you can see that as the time goes with the follow-up months from 0 to almost 1 year, 2 years, up to 4 years, the adherence to statin therapy actually can decrease the cumulative mortality, whereas the pink line, that is the no adherence to statin therapy, is responsible for increasing the cumulative mortality rate. So here comes the real benefit of bempedoic acid, where you are actually having a lot of oftentimes that statin intolerance or non-adherence because of so many sometimes some side effects like myopathy or sometimes increased uh, LFT or enzyme liver enzymes, or sometimes some rhabdomyolysis, which sometimes can happen in very high density statin therapy. So ATP citrate lyase inhibitors, that means the bempedoic acid, which is the first molecule in its class, has something to play the role. So bempedoic acid is approved as indication with reduced uncontrolled LDL-C on top of that statin, or in place of statin, in the form of 180 milligram orally with or without food, and with maximum tolerated statin dose, or in mixed dyslipidemia, or in familial hypercholesterolemia, or in high risk of ASCVD patients where the LDL-C target is not being achieved by statin alone, or being poor adherence to statin therapy, or intolerant therapy. So again, as we can see here, that the guidelines as far as the unlocking of the confidence nationally and internationally, where we are standing right now, is actually, which starts from approval from US FDA in 2020 February, then gradually the European medicine agency, that is EMA, approved it in March 2020, followed by our own, that is Lipid Association of India recommendation came in August 2022. ACC already recommended for afterwards in October 2020, and in March 23, that means this year only, that clear outcome, which is a CVOT trial, came with the promising result of bempedoic acid. And at present scenario, that is, we are considering about the recommendation from International Lipid Expert Panel, IELP, who recommended the molecular therapy, that is bempedoic acid therapy, from April 2023 onwards. So how does it work? As we all know, that statin has a very, very promising impact in the rate limiting enzyme of HMG-CoA reductase, which is responsible for, for the formation of the cholesterol in the pathway of the whole cascade of that cholesterol formation gets actually arrested at the level of HMG-CoA reductase by application of statin, which is one of the rate limiting enzymes. But the other molecule, that is the bempedoic acid, comes in a little upstream of this cascade. That means it actually inhibits the ATP site, that ACL. That means that ATP citrate lyase inhibitors, it actually inhibits. So how does that ATP citrate lyase enzymes works? So it actually inhibits the formation of acetyl-CoA by inhibiting that pathway or that particular chain reaction where there is formation of acetyl-CoA from ATP and coenzyme A. And this is very upstream of formation of HMG-CoA itself, and it inhibits the pathway or the whole cascade in a very initial part of the whole reaction cycle. So how does it work, or where does it work? So as we all know, that it has basically a very tissue specification, or the location of the particular enzymes lies only in liver and kidney, not in the skeletal muscle. So mostly the control of this pathway happens in liver, and in kidney there is some amount of adverse effect of the, or untoward effect of this molecule happens in the form of accumulation of uric acid, because it inhibits some transporter, that is OAT2, in the at the renal tubular level, and in the muscle it is completely absent, so it doesn't have any effect. on skeletal muscle in the form of rhabdomyolysis or myopathy. So it is the advantage as far as its mechanism of action is concerned. So management of patients in bempedoic acid therapy, if we consider the main excretion comes from the kidney, not in other way, and 5% only in feces. The half-life is 21 years as far as the pharmacokinetics is concerned. It gets in its active metabolites, converts into its active metabolites in liver. So there is no actually dose reduction or adjustment is required in case of renal impairment, even in case of end-stage renal disease. Sorry, although it is not studied in end-stage renal disease, but in hepatic impairment, it is said that yeah, no doses adjustment is necessary. But having said that, it is not well studied in severe hepatic impairment also. So it has that level of safety margin in renal impairment and hepatic impairment. At the same time, monitoring has to be done in case of some increased serum uric acid level in the body, because I said that it has some unexpected result in accumulation of uric acid, forming gout or hyperuricemia, and you should be little vigilant in the patients of more than 60 years of age getting corticosteroids or fludrocortisones or renal therapy, particularly if there is history of tendon rupture, because that may be sometimes important to consider its advocation. But it is definitely to be discontinued in a patients of those subsets where you are actually having renal failure or history of tendon rupture in a patients of more than 60 years, taking corticosteroids, taking simvastatin or pravastatin of more than 20 or 40 mg respectively, should avoid concomitant use. And last but not the least, in the patients of pregnancy or breastfeeding, in both occasions, they are not recommending the molecular use. So the clear outcome trials, which is our main concern of this talk, that came actually in March 2023, and that Dr. Stephen Emission, on behalf of CLEAR investigators and our extraordinary patients, substantiated that bempedoic acid and ATP saccharide reduces low density lipoprotein or cholesterol levels and is associated with low incidence of CV events. So how was the CVOT study of bempedoic acid was designed? These primary and secondary prevention patients in elevated LDL-C and statin intolerant patient. The statin intolerant patients were screened first for 5 weeks, then 4 weeks run-in period treatment with single blind placebo was done, followed by the visit was done giving bempedoic acid in one arm and in placebo in one arm, with almost 7,000 and 7,000 patients in each arm, with the study completion of 1,620 primary patients of 4 component of MACE, 3 component of MACE, and the treatment duration was lasted of at least 2 years. With that endpoint, the primary endpoint was considered the effect of bempedoic acid versus placebo for 4 component MACE, CV death, non-fatal MI, non-fatal stroke, coronary evascularization, and median follow-up of more than 40 months. They incorporated patients of almost 14,000 patients, and in phase 3 clinical trial, what they actually tried to look at, that the statin intolerance happens in almost 15% treated patients and prevents patients from achieving LDL-C levels and cardiovascular benefits. So here comes the role of this particular molecule. which is concerned in primary and key secondary endpoints. So primary endpoint, 4-component MATs, which are non-fatal MI, non-fatal stroke, coronary revascularization, and cardiovascular death. And hierarchical testing of key secondary endpoints are 3-component MATs. That means MI, stroke, or CV death, excluding only non-fatal MI. Fatal and non-fatal MI also was considered in the hierarchical testing of key secondary endpoints, followed by coronary revascularization, fatal and non-fatal stroke, cardiovascular deaths, and all-cause mortality. So that is different way of looking the, the outcomes to come to the endpoints or to have the endpoints of this study. So the demographic data as far as the body mass index, LDL level is concerned, like median high density, high sensitivity CRP, that renal status, cardiovascular risk category like primary prevention patients, secondary prevention patients with or without having coronary artery disease, peripheral artery disease, cerebral disease concern, all are having comparable data in both the arms, that means in placebo and Bemdac group. As you can see here, there is no discrepancy, much discrepancy in these two groups. Even as far as the glycemic status or statin use is concerned, almost there are comparable data in both the arms at baseline. But if you consider the clear outcomes, that there is glaringly 4-point miss. If you consider there is significant relative risk reduction of 13% at the end of the study, or in the whenever you are considering the endpoints, there is 13% risk reduction, which is very statistically significant. The 3-point MACE reduction happens in the tune of 15%. As you can see here, the hazard ratio also, you can see that a hazard ratio is 0.85. That means 15% of 3-point MACE reduction, which is definitely significant. And if you consider the fatal and non-fatal MI, 23% relative risk reduction. As you can see here, that hazard ratio is 0.77, and coronary revascularization risk reduction happens in the tune of 19%. And all the cases, you can see that p-value is less than 0.05, which is statistically significant. So effect of trial regimens on CV events among statin intolerant patients, treatment with bempedoic acid was associated with a lower risk of 4-component MACE, 3-component MACE, coronary revascularization, and fatal and non-fatal MI. So as we already discussed, this is the major advantage of having this particular molecule in our prescription. And clear outcomes also looks at that that LDL-C reduction happens in the tune of 21.7% compared to placebo. With the time goes on, like almost at the end of 5 years, it decreases the LDL-C in the tune of 26%, and in comparison to placebo, it is almost 21.7%. At the same time, not only the LDL-C level, it decreases high sensitivity CRP level also. Surprisingly, at the end of 6 months, when there is definitely a rapid reduction of hsCRP in the tune of 22%, there was relatively increased margin of hsCRP in placebo arm. But at the end of the trial, it has been seen that there is actually 19%, more than 19% of reduction of hsCRP in contrast to placebo use. So if you consider about the hazards or the adverse events, so there is not much difference in the serious adverse events comparing placebo with bempedoic acid. But at the same time, there is adverse events leading to discontinuation of the drugs happens in 10% of the patients, whereas in placebo also this is almost comparable data. Myalgia also doesn't happen much compared to placebo in bempedoic acid, but there is one significant increase in the hyperuricemia in comparison to placebo group, and slightly increased percent of gout in contrast to your placebo. And there is change of baseline uric acid after 6 months, which is definitely a concern in contrast to placebo arm itself, which may sometimes can result in gouty arthritis or hyperuricemia. At the same time, I like to mention that renal impairment is also to be looked for whenever you are considering about bempedoic acid usage. So bempedoic acid becomes a fast ACL inhibitor and fast oral non-statin to demonstrate statistically significant reduction of MES4 events in patients who are having higher risk of CVD with documented statin intolerance and elevated LDLs. So to conclude, bempedoic acid an effective alternative for statin intolerant patients, which is derived from clear outcome. It is well tolerated drug with mixed population in primary or secondary prevention purpose who are unable or unwilling to take statins. It has the LDL-C and HSCRP reduction potentiality in the form of almost reduction of 21.7% of LDL-C and HSCRP in the tune of more than 22%. Although there is small increase in incidence of gout and cholelithiasis, but primary and secondary endpoints are definitely achieved in clear outcomes in the tune of 13% of 4-component MES reduction. 3-component MES reduction happens in 15% cases. Myocardial infarction and coronary vascularization requirement is also reduced in the tune of 23% and 19% respectively in the bempedoic acid group compared to the placebo group. An effective approach should be as an alternative or effective approach of statin, particularly in statin intolerant patients or in addition to statin. Thank you.
Thank you so much, sir, for this wonderful presentation. There are a few questions which have been raised online. I would like to ask those questions. So this first question, sir, initially you were talking about ESC 2019 guidelines, which are becoming stricter as in comparison with 2016 guidelines. So there's one question related to that how low LDL cholesterol one can achieve, and is there any neurological complications one observes when LDL cholesterol is below 30 milligram per deciliter?
So this is very interesting. Like they have actually came down in the number from moderate risk group onwards. So if you see that in moderate group onwards, they have come down even below 100 mg per dl of LDL level, and in high risk group they have came down even below 70. That means they have came down almost. They have come down almost in the level of 55 mg per dl. So I would say, as far as the Lipid Association of India is concerned, they are more in favor of reducing the the level of LDL-C in high risk group, and they are considering this number should be almost 30 in case of very high risk group, when it is considered to be extremely high risk group. Now, as you asked about the neurological events which might be really a concern for the population of the patients who are getting the benefit out of statin. So previously it was thought that dementia and other things may be precipitated at some time by usage of statin, because you are actually wiping away the cholesterol level from the body, and cholesterol, as we all know, that is a precursor for a lot of lipoprotein, which is important for our metabolism, particularly that different hormones like that important for playing roles in the body. At the same time, they are having roles in lipoproteins for membrane formation across the neuronal junction, and all this can be may be considered as an hypothesis, but it actually didn't result in the clinical scenario, as we apprehended that the lowering of the cholesterol may actually affect that neuronal status, but it really didn't happen, or nobody could be able to demonstrate it in any of the study. So maybe it's an anecdote, but in real life scenario, it may not be still concerned as far as the CV events or the CV risk is concerned. So uh, this may not actually preclude the use of high intensity statin therapy, or reduction of LDL. See, at that level, may be actually a concern as far as the neurological adverse events are considered.
So thank you so much, sir, throwing light on this aspect. This next question, that my patient is diabetes, and she is also a pregnant lady. So she's in 8 months of her pregnancy. Is it safe to give bempedoic acid in this lady?
So first of all, in pregnancy or lactating women, it is not actually advocated. So this is very clear. The second thing is that, yeah, you can consider about bempedoic acid even in patients of diabetic subset, because although there is some amount of slightly increased risk of diabetes, new onset, particularly new onset diabetes mellitus in bempedoic acid arm compared to the placebo, but you never know whether it came as a result of the natural process, or it actually uh, occurs as a result of your bempedoic acid usage. So that hypothesis will require little more understanding and more data. But at the same time, I would say that your benefit of usage of bempedoic acid, particularly if you are unable to administer other lipid lowering agents, particularly statin, it will be definitely uh, you know uh, out risk your formation of diabetes mellitus in this subset. Yeah, but definitely in contrast to your placebo arm, there is slightly increased number of new onset diabetes mellitus. So with that, you can take the message with some pinch of salt.
Yes, sir. This next question, this is talking about my patient is 60 years old, and he is facing difficulty in when I increase the dose of statin, like rosuvastatin 20 milligram to 40 milligram, he is complaining about muscle related symptoms. So should I keep the dose of this rosuvastatin 20 milligram and add bempedoic acid, or should I stop rosuvastatin 20 milligram and give bempedoic acid plus azathioprine combination?
Right. So basically, the statin intolerance doesn't mean like whenever you already have advocated high intensity statin, you have to stop the statin usage completely. So statin intolerance may happen as a general phenomena in a high intensity statin group, even in moderate or low intensity. Now, if you consider about high intensity statin intolerance, then definitely there is an window opportunity of window to come down in the dose, and you can always consider about adding the other molecules, and you can also look at the other contributing factors like your uh, as I said, your vitamin D deficiency or your thyroid level, and definitely in the form of your CPK level or creatine kinase. So if you feel that your myopathy is precluding the high intensity statin, you should actually come down in the statin dose. But complete abstinence of statin may not be prudent. But at the same time, you can actually add the other molecules, maybe ezetimibe or bempedoic acid or something other. But yes, if you are considering that statin is not being even taken, even in very low dose also with definite evidence of your rhabdomyolysis or maybe sometimes a very severe degree of hepatic impairment in the form of enzymes rise, and at the same time the person will definitely require some medicine which has to take care of the LDLC level, then you have to consider about the other therapy, maybe in the form of fixed dose combination or monotherapy, or maybe the last or maybe not the least, that PCSK9 you can consider. But before considering it completely statin intolerant, you can actually come down in the dose of statin, and you can consider about switching to the other molecule
This was nice into it was indeed nice having you on this evening talking about clear outcomes trial and clearing all our doubts. Sir, thank you so much. I would like to thank all the delegates for today's uh, attendance and your active participation. From we'd like to thank from Zydus Life Sciences point of view. Sir, this was a wonderful session. Of course, uh, there are many more sessions to come, and we would like to be a part of these sessions in coming days as well. So, thank you for imparting knowledge and your in clinic expertise along with this clear talk. Will definitely help all our delegates to practice day-to-day life, and with this your expertise definitely they will uh, control the LDL cholesterol pretty well. I would like to hand over this session to Asadda for vote of thanks.
Am I audible, Satish bhai? Hello, hello.
Yeah, you are audible.
Oh, okay. Sir, very good evening. First
Thank
of all, I would really like to thank you for giving precious time of yours for this Bemdac, which was very interesting and it was very lucid presentation from your end. Thanks a lot. I really want to thank secondly to all the delegates for turning up and giving their time for today's session for Bemdac, for Bemdac. And definitely, I would really like to thank Satish Bhai from head office and our tech support team for organizing this program and helping us to conduct it. And definitely, most importantly, I will be missing. It will be not great if I will not name after the name of Sandeep and Akash for organizing this, following up with Sir for giving his precious time. Once again, thanks a lot for the entire Zydus Medica team. And sir, thank you very much once again. I am sure we will like to continue such academic platforms and academic events more with you, with your permission and with your dates availability. And with this, I want to end this session of today's web talk, and we'll do more academic sessions in months and years to come. For entire Zydus Medica team, very good night to all of you.
Thank you again, Jaidas, for having me for such a nice platform on discussing on bempedoic acid or lipid lowering agents. So many doubts we could be able to address, and we can actually get a uh, very interactive session today. And we hope that we'll have this kind of session in the future also, either in the form of CME or kind of lipidology, or maybe something else which we will endorse. So thank you once again and good night.